Good morning, everybody. Sorry not being able to be with you. It's a great pleasure to show a recorded live case that we performed, the tricuspid TEER. So briefly, I will go through the history of the patient. This is a 79-year-old female patient, severely symptomatic with diabetes, permanent AF. Most of these patients have got chronic AF. There's some renal dysfunction. NT-proBNP is elevated. Left ventricular ejection fraction is maintained. Euroscore 2 is not very high, but TRI-score is 8 because patient is on high dose of diuretics and has got severe symptoms because of tricuspid regurgitation. And this is how the tricuspid valve looks like. You can see dilated annulus, you can see horizontal leaflets, a central jet of tricuspid regurgitation, pretty broad jet. So it spans from the posterior to the anterior part of the valve. The valve looks tricuspid. There is a hint that there might be some separation of the septal leaflet, and I will urge everybody that deals with TTR to perform a very good transgastric view or try to get a transgastric equivalent from the NPRs, from the RVO. It's very important to identify the anatomy of the leaflets. So we thought this is a favorable anatomy for TTR, and as Dr. Shuvy mentioned earlier, we opt now for the Clover technique. So the rationale will be to clip the septal and the anterior leaflet as well as the septal and the posterior leaflet, thus creating tissue bridge quite uniformly alongside the coaptation line of the tricuspid valve and also create some direct annuloplasty. These are the right heart catheterization values, a moderate PA pressure. The wedge is not very elevated, but the right atrial pressure is elevated, which is consistent with the severity of the tricuspid regurgitation. There is also reduction in the cardiac outputs, but the pulmonary vascular resistance is not that high. So this is a TTR with Pascal device. I just fast forwarded it a little bit. So access is through the right femoral vein. The device is already in place. We're flexing down towards the tricuspid annulus on the top left. You can see the echo top right. You can see the fluoro. You aim to create almost a 90 degrees angle. And then once we find our position above the tricuspid annulus, we switch to the right ventricular inflow-outflow view. On the left, you can see we go to the anteroseptal region. We try to get perpendicular access to both axis, and once we open the arms, we go to the transgastric views. We really push a little bit more anterior. We want to be to the anteroseptal region, and we try our clocking to be perpendicular to the coaptation line. In this particular patient, we decided to grasp both leaflets on the transgastric view. We do that quite frequently these days. We go to the lateral part of the valve first. We make sure that the leaflet is within the arm of the device, and then we just switch to the septal leaflet. Here, the device is open. We are happy that both leaflets are in, and then we try to close the device while we have the leaflets on view. This is an effort that is being done by the echocardiographer. You can see both leaflets are in, and once we're happy, we close the device, and we can be absolutely sure that we have very good grasping even on the transgastric view. You can see now how the leaflets look like, leaflet insertion here. Then we decide to deploy the first device. Anteroseptal grasping has been performed. We still have some residual TR coming from the central part of the valve, just posterior to the initial clip, but that was the initial aim to put a second device, which is coming now, more posterior to the initial one. On the fluoro, it will be just below the first device, the first Pascal device. Again, flexing down to the valve is not a problem, especially when you have one device, you have your anatomic landmarks on the fluoroscopy. You try to get coaxiality on both planes by flexing adequately and making sure we come above the collar here in the collar area. And then again, we open the arms of the device and we switch to transgastric view. Now it's important to find ourselves in the posterior part of the valve here. And we need to make sure that we have very good clocking So perpendicularity in that particular area is very important. So here we rotate a little bit clockwise. So you can see on the fluoro both of these devices are in different rotations. So we have to rotate our image in order to have the second device profile. Here you can see our clocking is good, and we found ourselves in the posterior part of the valve. And then we switch to the RVO view. In this particular patient, the echocardiographer Elias Ninios felt more comfortable grasping in this area once we found ourselves, because you have to be patient to get the right views. You can see that now the lateral leaflet is in the posterior leaflet, and now we switch to the septal leaflet. Almost in all cases, we grasp separately the two leaflets, and once both leaflets are in, we can close the device very, very slowly, making sure that we have maintained both leaflets. Here you can see the closing of the device right now. So both leaflets are in, the grasping is pretty good, and the color is practically eliminated. And now you can see the clover that Moni Shuvy actually discussed earlier on, two tissue bridges on the transgastric. One is coming anteroseptally and the other is coming posteroseptally. Now our focus, of course, is to ensure the leaflets are in, so we can afford to open the device, look at the leaflets, make sure the leaflets go all the way into the base of the arms, and then we close the device again. So this is the clover technique. And actually, this is the final result. You can see there's a trace of tricuspid regurgitation. Admittedly, this is a good case. This is an AF case with preserved LV ejection fraction, with very good imaging. But these are the cases that we should be doing. The patient was severely symptomatic, but not fully decompensated, as you could see. This is a very interesting aspect. Look at both devices. One is anteroseptal, the other is posteroseptal. You can see both devices are moving almost independently to each other, following the motion of the leaflet. And this is something that we really like in these devices. So that is the end of my presentation. I'm very happy to take questions and discuss any issues.
Yeah, excellent case, and exactly what you were saying, Dr. Shuvy. They are one anteroseptal and one posteroseptal, and interesting. Do you also see all the time this independent movement, or it happens?
Great case. I always do as Vlasis does. I always do independent grasping. I always get the lateral first and then slide slowly to the septal and grasp it. Always start in the anteroseptal and then add the posteroseptal because of the imaging issues. The posteroseptal is more challenging. It's more challenging. You're going to the posterior part. There's more cords there. The imaging is more challenging, and therefore you should be very careful when you are there. But definitely aiming a clover technique is I think our best chances to get a long-term outcome which is suitable and good for the TEER in this condition.
Dr. Yakouvou?
So congratulations, Vlas. Thank you for being even remotely here. We enjoyed your presentation, and in regards of what Moni Shuvy just said now and before. So is it advisable now that we should all aim, if anatomy permits, to go for clover technique, to have two grasps, or in the anterior, posterior, anterior septal and posterior septal? Is it advisable?
Vlas, is this a routine that you do that similar to Dr. Shuvy?
Absolutely, 100%. And this is the modern way of performing TEER these days with both devices. I just showed the Pascal device, but do the same with the TriClip. And I share all the concerns and the difficulties with Moni regarding the posteroseptal region. Imaging is more challenging, more cords there. However, if you can do that, you should do that, because really it's a more balanced and symmetrical way of repairing the valve. Your indirect annuloplasty effect is also more symmetrical. And there is some evidence, if you look into the Triluminate sub-study, it was presented in EuroPCR about a year ago. I'm not sure if this evidence is published, but it looks that the results when you perform a clover is actually more sustainable and more durable compared to a simple anteroseptal tricuspid TEER.
Mihaly, your opinion about this approach?
I think it's very interesting, and I wonder how much you persist with your first device in getting the maximal TR reduction, because getting a second device in has its own inherent risks and generally speaking, it's not always guaranteed that you're going to be able to do it in the way you want to do it. So we would like to see our first device, and that's why we spend a lot of time in optimizing the position and leaflet insertion to get a maximal reduction. And only in that scenario we would consider a second device if we don't get adequate TR reduction. So I wouldn't necessarily generalize this to be like a routine approach for two devices. I think it's a bit problematic if you don't try your first device to get the maximal result with your initial device. And that reminds me also of the initial MTR experience when we would be putting multiple devices, and then we went back to putting one or two devices at most in our mitral space because we wanted to optimize and get minimal devices, a number of devices in, if possible. So that's my concern.
Well, out for consideration then.
I share these concerns.
Yeah, go ahead, Lassi.
If I can make a quick comment, I do share these concerns. And obviously, Michalis is extremely experienced, and we all know that it might not be feasible to perform Clover in all patients, especially in the posterior area. There might be anatomic variations that will prevent you from actually being successful. And you're also running a risk of SLD or getting trapped in the cords. However, we have to take into account the fact that the patients are sedated. And what you get acutely on the table with TEE, you may get disappointed the following day when the patient is awake. You may find out new jets coming from the posterior area that you didn't account for. And it is really disappointing to put like one or two clips anteroseptal and having avoided to put a posteroseptal device that you might have had a better result. But of course, I share these concerns.
Okay, thank you so much. It was so interesting, all this discussion. Thank you for your contribution, Vlasis. So let's proceed to